Welcome everyone to the June webinar focusing on infection prevention and control processes that can inform our work in QI. My name is Mary Mano. I'm a family physician by training, and after 35 years in practice, I came to work in the QI program at the CPSO in 2019. Thank you for joining us today. We're grateful for your continued support and interest in our webinars. This will be our final monthly webinar, but stay tuned. We'll be back in September with an update on plans for the 2024 QI program. As part of our commitment to acknowledging the diversity of those we serve, the CPSO acknowledges the lands on which we work, practice, and live. While a singular land acknowledgement can never capture the richness of our distribution across Ontario, I'd like to offer an acknowledgement that the land on which the CPSO is located at 80 College Street is traditionally the territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is home to many diverse First Nations, Inuit, and Métis people. Today, it is home to Indigenous peoples from across Turtle Island. We're very grateful and honored to have the opportunity to work in community on this sacred and traditional territory. Today's webinar focuses on the application of IPAC principles in QI, and the webinar is being recorded and will be later available on the CPSO's YouTube channel. We have with us today two guests from Public Health Ontario, Dr. Maureen Cividino. Dr. Cividino graduated from McMaster University, obtaining her MD and CCFP certification. She has worked for many years in a Hamilton Group family practice. Dr. Cividino is also an occupational physician certified by the Canadian Board of Occupational Medicine. She holds a diploma in occupational health and safety and maintains CIC designation through the Certification Board of Infection Control and Epidemiology. She provides IPAC physician support to Public Health Ontario and works in occupational health in acute care. Rohit Garg is an IPAC specialist at Public Health Ontario. He is a foreign-trained doctor with a master's in public health from Yale University. Rohit is a Lean Six Sigma Green Belt and is certified in infection control. He has over 15 years of experience in infection prevention and control, working at various healthcare organizations in both the US and Canada. He has a special interest in supporting IPAC practices in clinical settings, which is good for us. So my plan today is to spend about 10 minutes giving a brief overview of the QI program. And I should just mention that a more complete description of the program can be found on the CPSO's YouTube channel within the webinar that is dated November 2022. And after I finish with the overview, then I'm going to invite our guests from PHO to present on the interplay between the IPAC principles and QI. So feel free to enter your comments or questions in the chat as we go along. Members of the QI team may address those during the presentation, but we also plan to leave lots of time at the end for questions about the QI program itself, as well as the IPAC component. So Harsh, let's move on to slide 2. We'll take a look at our objectives for today. So at the end of this session, our hope is that participants will be able to explain the transition at CPSO from quality assurance to quality improvement, understand the CPSO quality requirement, know how to access and utilize IPAC best practice resources which are available from Public Health Ontario, and use self-assessment of IPAC practices to inform practice level QI. Next slide, please. So let's move on then with the overview, and let's go to the next slide. So this diagram is a way of expressing what we're working on at the CPSO in terms of our mission, some of the principles that we use in regulation. And of those, there are a couple of key design principles that are at the heart of the QI program. One of those principles is right touch regulation, and the other is a quality improvement approach that is the strategy that we've used within the quality programs. Next slide, please. So right touch regulation is an interesting concept. It ensures that the level of regulation is proportionate to the level of risk to the public. And that principle is applied at the CPSO to all aspects of our work, be it registration, quality programs, or investigations and complaint resolutions. Next slide, please. So if we look at the background of the quality program at CPSO, it's important to recognize that the quality assurance is a regulation within the legislation, and all physician members must participate in a quality program by statute. So historically, the peer and practice assessment program's been around for, I think, around 30 years. And the idea was to get around to every physician in Ontario every 10 years. In 2019, the decision was made to pivot from quality assurance to quality improvement for the majority of members. And at that point, we were continuing with peer assessment for those over the age of 70. Next slide, please. This diagram um, illustrates another key principle in the quality improvement process on which the programs at CPSO are based. And as you may know, the CPSO was making the shift from quality assurance to quality improvement. And the reason for doing this is that quality improvement is a data-driven process that will help us to identify areas of improvement. And the goal is to get above the current standard, whereas a QA approach is based more on verification against a minimal acceptable standard. So I like this slide because it illustrates that on the left-hand side, when you think about members within that distribution, um, action or assistance is really being offered to a small number of members who fall below that threshold of that we could call the minimum standard of care. Whereas on the right, in a quality improvement model, action and advice and improvement can occur for all members, no matter where they're starting from, and shifting the whole curve to the right, which is a has an impact on a larger number of members and therefore likely to have a greater impact in the long run on quality of care. Next slide, please. So the quality improvement program, sorry, I've got two different slides, not to worry. The quality improvement programs at CPSO then are based on right touch regulation, a QI-based design, and more frequent engagement with physicians. And we're looking at contacting every physician in Ontario every 5 years. And there are two streams within the programs that will allow us to do that. The first is the QI for individuals stream, which has a subset called groups, and the second is QI partnership. Partnership draws from physicians who are hospital-based, whereas individuals and groups mainly consists of community-based physicians. Next slide, please. In 2023, we also are piloting an option that's called QI Enhanced. And here we've created the opportunity for physicians between 70 and 72 years of age, whether they're hospital-based or community-based, to participate in QI. And we're going to take a look at how that works for them as opposed to the previous approach of peer and practice assessment for those over the age of 70. So stay tuned for feedback around how that pilot turns out. Next slide, please. So this slide's a bit busy, but what we're attempting to do here is to summarize what the options are for members participating in a quality program at CPSO. And so, as you can see, there are a number of QI activities that are required, and that varies depending on which stream you're in. So in QI for individuals and in the group subset, there's the practice profile activity, self-guided chart review, and the data-driven activity. The difference between the two is that if you're working as a group, you submit one practice improvement plan. If you're working individually, then of course each individual submits their own practice improvement plan. Whereas in the partnership program for hospital-based physicians, those folks are required to complete 2 QI activities, and they'll be participating in the hospital QI initiative as a group. under the auspices of the hospital itself. And then the alternative, of course, which still exists, is the quality assurance model of peer and practice assessment, which involves completing a physician questionnaire and an on-site assessment. Next slide, please. If there are any questions, there are a couple of options here where you can email us, but please feel free to make some notes and we'll come back to discuss further at the end of the IPAC presentation. So I'm going to turn it over now to our guests from Public Health Ontario. Take it away, Maureen.
Um, I will be starting it.
Take it away, Rohit.
Well, good afternoon, everyone, and thank you, Dr. Mano and the rest of the CPSO QI team for inviting us today to talk about how to strengthen IPAC program in primary care settings using a QI approach. Next slide. So the learning objectives were already covered, but specific for IPAC segment we have today are that at the end of our presentation, participants will be able to describe the importance of IPAC practices in primary care, outline the components that make an effective IPAC program, describe how to access and utilize IPAC best practice resources available from Public Health Ontario, conduct self-assessment of your IPAC practices and improve them using a multimodal approach. Next, please. So let me begin by introducing my organization, Public Health Ontario, or in short, PHO. PHO is an arm's length provincial agency that provides scientific and technical advice and support to various government and healthcare organizations. We generate evidence-based practices and build capacity through education and consultation. We are different from your local public health unit, whom you might be more familiar with and sometimes get us mixed up with sometimes. Next, please. So there are many reasons why we need a robust infection prevention and control program in clinical settings today more than ever before. Mainly because the public expects that the patient safety in clinical offices is equivalent to that in hospitals. In 2015, the Infection Prevention and Control Complaint Protocol was updated to mandate public health units to investigate IPAC complaints. Following that, in 2019, the public health units across the provinces were surveyed to learn more about the IPAC complaints between the years 2015 to 2018. And just to clarify, Public Health Ontario doesn't do these investigations, the health units do. We only provide risk assessment support to them. Results shown here from that period, the IPAC complaints increased almost by sixfold and IPAC lapses by threefold. The complaints range from failure to adhere to IPAC best practices to a lapse where there's a risk of transmission of infectious diseases to patients or staff. Approximately half of these reports are related to clinical office settings. Majority of the identified issues were related to reprocessing of medical equipments, devices, absence of policies and procedures, and about a third related to environmental cleaning and education. Now, just this past May, the WHO, World Health Organization, ended the global COVID-19 emergency. It doesn't mean that the pandemic is over, but what it really means for us is that aside from COVID-19, we need to also focus on other infectious diseases that can be transmitted in healthcare settings and implement effective control measures. Next slide. So the question is what it takes to build an effective IPAC program. It is actually a continuum of implementation to monitoring to making improvements using multimodal strategies. The components or the strategies as shown in the boxes here are education, the policies based on the regulations and best practices, physical environment and resources to support such practices, and leveraging on facilitators in your facility, and finally, support from the leadership. We use all these strategies or components, whether we are establishing our IPAC program from scratch or trying to make improvements in it. We will now go over these supports for each of these components. Next slide, please. So let's begin with IPAC education. This can be accomplished by completing IPAC core competencies. These are the basic skills and knowledge that all Ontario healthcare workers need to know. These support healthcare workers and staff to consistently implement IPAC practices. There are about 7 modules as listed here, and each takes about 10 to 15 minutes to complete. You have to register to start them, and at the completion, you will receive a certificate of completion. The Occupational Health and Safety Act sets out duties of employers, supervisors, and workers to provide a safe workplace. This module, the first one, um, it summarizes those duties and helps us create an internal responsibility system. It also helps us in understanding the procedures for reporting work-related injuries and illness. Next one is the chain of transmission. This is widely used model that helps in understanding the risk for transmission of illness in healthcare settings and how the chain of transmission can be broken. It also helps in understanding organizational and personal risk assessment. The last module that was added in this suite was the personal risk assessment in community clinics. It is a scenario-based learning for selecting PPE and appropriate for the task at hand and to be prepared for any patient encounter. Similarly, we also have learning modules for those who are involved in reprocessing of medical equipment at their practices, but not shown here. It is recommended that these are completed upon hire, then a refresher can be planned based on the annual review of any changes in the processes or equipment as determined by risk assessments and results of previous audits. A link is provided here on the slide and will also be shared after the presentation is over. Next slide, please. So Public Health Ontario has developed numerous IPAC resources specifically for clinical office settings that include PIDEC best practice recommendations, along with the tools to help with their implementation. So these resources can help you understand how to set up your physical environment of the clinic that is conducive to IPAC practices and what materials you will need at point of care, such as alcohol-based hand rub and personal protective equipment. Most of these recommendations can be followed easily by start making small changes and not necessarily thinking or envisioning big renovations to begin with. Similarly, and finally, they can also be used to draft your IPAC policies and procedures. We also have resources that cover individual key areas in IPAC programs, such as all those listed here: environmental cleaning, hand hygiene, routine practices, and additional precautions, etc. In case you need additional information to learn more about these areas. The link provided here takes you to our webpage dedicated to the resources for clinical office practices. Next slide, please. So a visual is always helpful to memorize and remember and find it familiar when you see it. So just to show, on the left is our PIDEC best practices document for clinical office practices. And on the right is a short and sweet version, I would say, and it's a fundamental summary of IPAC key principles for clinical office practices. That contains all the helpful links and in short summary of each of those key program areas, as I mentioned in the previous slide. This will make it easier for you to follow all the recommendation and find what resources you need and where to implement them. Next slide, please. So now that you're familiar with where to find our IPAC best practice resources and how to go over them, you would now like to compare them with the IPAC practices that currently exist in your clinical office. A quick and easy start is using our checklist. And as you go over assessing items from the checklist one by one, you should be asking yourself some questions. Is this a usual practice? Are there any prior audits available to support that? Are there any policies and procedures to support this practice? And has anyone or everyone received education on that? Are there facilitators in place, such as signage? One of the facilitators, I just was reading a paper recently, and it was related to, we have been overusing or using numerous PP for long hours. And a simple measure, just turning down the temperature in the room, helped the healthcare workers to get through the day. So these are facilitators. So do you have those in place? Using a quality improvement approach, you can use these checklists for gap finding and developing an action plan for priority items. So Maureen, my colleague, is now going to talk about this approach by using some examples. So over to you, Maureen, and next slide, please. Sorry, Maureen. Okay, I think I will get going until Maureen is able to join. So here we are presenting you with top high risk, 5 high risk practices that have been studied and found a lot common to be the case when conducting IPAC labs investigations out there. These 5 areas go over from lancets, glucometers, insulin pens. So what is the expectation is that
Sorry,
lancets hub.
I'm
Oh,
sorry, can you hear me now?
yes, we got you. Thanks.
Okay, can you still hear me? Can you hear me?
Yes, we hear you, Maureen.
Okay, all right, sorry about that. And thanks very much for picking up there, Rohit. So just a little more background on infection transmission in clinical office settings. And then I'm going to demonstrate a couple of examples how the checklists are actually well suited for developing practice improvement plans. So going back to 2013, that's when the clinical office best practice document was first published. And that was a joint effort between CPSO actually and the PIDAC, or the Provincial Infectious Diseases Advisory Committee, which is a part of Public Health Ontario. And it came about as a result of concerns in Ontario of documented infection transmission in endoscopy clinics, including cases of Hep C related to medication used for sedation. There were also issues noted in pain clinics, and one pain clinic associated actually with multiple serious bacterial infections, including meningitis and deep soft tissue infections. So a systematic review of the literature was completed in developing the document. And of the many high-risk practices, these 5 on the slide were determined to cause the greatest risk of infection transmission. So lancets and hubs are to be single use only. Glucometers and insulin pens must be single patient use only. There have been multiple outbreaks of hepatitis B and C related to the reuse of lancets and hubs, glucometers, and insulin pens. It was a common practice, and I recall even in my own family practice, that there would be a communal glucometer that would be used on multiple patients. And if somebody presents with symptoms that may be related to diabetes or hypoglycemia, it was always helpful to be able to use that as an adjunct to your clinical assessment. But as of 2014, Health Canada then stated that all glucometers must be single patient use only unless designed and approved for use in multiple patients. And all cleaning and disinfection recommendations as per manufacturer's instructions for use needed to be followed in between use. And the Institute for Safe Medical Practices, or ISMP, reflagged these practices as an ongoing issue in 2021. We also know that there have been many outbreaks in long-term care related to exactly that, using a single glucometer and going in between patients. So it's something for consideration. Blood collection devices, which continue to be an issue. In fact, Public Health Ontario is looking into a situation at this moment in terms of an IPAC labs related to that. So if you draw any bloods in your office or you contract out, make sure that you have single-use blood collection tube holders. They're preferred. If you do have a reusable blood tube holder, it must be cleaned and disinfected again as per manufacturer's instructions for use in between patients. because there have been significant outbreaks of hepatitis B and C related to the contaminated blood collection holders. And if you have any tonometers in your practice, which is used for measuring eye pressure, or any other ophthalmologic equipment that touches the eye surface, it must undergo high-level disinfection, which is typically with glutaraldehyde in between patient uses, or at the very least having tonometer tip covers that are disposable. And just cleaning with an alcohol swab, for example, is not sufficient. The other issue for eye clinics, there's a high risk of adenovirus outbreaks, and they can be very contagious and very difficult to control. And one other, just a tip in terms of if you have any eye drops in your clinic or ointments, ideally they would just be single-use minims for the drops and the little single-use packages for ointment, because they notoriously get contaminated. And you can imagine if you're holding a drop close over an eye, the automatic reaction of the lid is to close, and then there's a splashback, and the tip often gets very contaminated. Then on to syringes and needles. It would seem certainly that it would go without saying that all needles and syringes are single patient use only. Of interest, the ISMP did survey over 5,400 healthcare workers, and 1% stated that they reuse needles, and 15% regularly reuse syringes, particularly for local anesthesia. So this would be where a needle is put into the bottle, medications withdrawn, injected into the patient, and then there is a new needle, but the existing syringe that had already been used is reapplied, more medication is withdrawn, and that is, although it feels like a vacuum and there shouldn't be any contamination of the vial, it does become contaminated, and there are a number of cases of, again, hepatitis B and hepatitis C as bloodborne infections as a result of this. When the workers were asked why they were continuing this practice, the answers ranged from they were unaware that they could cause harm, or there were issues regarding cost containment or concerns regarding environmental waste. And it should also be noted that actually until the mid-90s, it was common practice to, in fact, recommended to reuse syringes in anesthesia, and in terms of looking at, again, protecting against environmental waste and cost. But it was 1997 that Health Canada put out a statement that all needles and syringes should be single-use only. And speaking then about vials, medication vials can be either single-use or multi-dose vials. Single-use vials are preferred. They're only used once on a single patient. Note that single-use vials do not have preservative in them, and so they're at high risk for contamination of bacteria. So you want to make sure that they are indeed discarded after use with a single patient. When a multi-dose vial is necessary, so for example, say with flu vaccine, where you often will have 10 doses in a bottle, never re-enter the vial with a used needle or used syringe, and a needle should never be left in the vial to be attached to a new syringe. Drugs most commonly associated with infection transmission include insulin, heparin, propofol, which is a common one, midazolam, and lidocaine. Methylprednisolone is also on that list. Most likely cause of hepatitis C in the endoscopy clinics for that transmission was related to reuse of single-dose sedation. And then finally, sterilization logs. In 2015, CPSO put out a document highlighting the top 10 issues noted in clinic inspections and several items related to reprocessing and sterilization. So sterilization logs, including indicators documenting successful sterilization, are required for all office desktop autoclaves, and they must document time, temperature, and pressure, which are the physical indicators at the completion of each load. So I would say, next slide, please. So this is an example of the self-assessment IPAC checklist. This one is for core elements, and there's also one that's for the sterilization. They have columns that can identify level of risk. So you see the red is in high, medium is in yellow, and the pale violet is for inform and educate. For practice improvement, you probably want to look at the higher risk items. And then there's also a column that if there is a legislated requirement, it has a blue bar. So if there's something, say, for sharps containers, which need to be CSA approved, or safety engineered needles, then there would be a blue bar as well. The core elements also include best practices for environmental cleaning, for example, making sure that you're using a hospital grade cleaning agent with a drug identification number and paying attention to expiry dates, sections on safe medication practices, again, ensuring that you have a separate medication preparation space and proper storage. Also a section on correct use of refrigerators, and often your public health folks will come in and may assist you with that, and checking the min-max logs and knowing that you need to be between 2 and 8 Celsius degrees. And also making sure that you don't have one shelf for medication, one for specimens, and your lunch in the door. So very important to have correct use of refrigerators. So the example on this slide relates to multi-dose vials. So if a multi-dose vial is used, it should be used for a single patient whenever possible and labeled with the patient's name. So an example of this could be injectable B12. Certainly there are allergy shots that would only be specific to that patient. And at the very least, if it is a multi-dose vial for, say, flu shots, must be labeled with the date first opened, and make sure that it's discarded according to the manufacturer's instructions for use or within 28 days, whichever is shorter. A very common error that physicians don't realize is that the manufacturer's instructions for use for lidocaine is to discard any remaining medication in the vial on day 4 of opening. So if you're doing a lot of procedures in your office, that's probably easy to do. If you're just doing, a few on Fridays, then there's a good chance that that you're going to be past the recommended date. Next slide, please. So then translating the checklist to your practice improvement plan, certainly you can use the SMART goals, and those are listed as one of the resources in the QI program. And infection prevention and control is actually perfectly set up for this type of auditing, which is a central continuing quality improvement practice. So for example, hand hygiene audits and audits of PPE are used routinely in hospitals and can be applied in an office setting. And it's sometimes small changes that can actually make a real difference for patient safety. So just as a reminder, the SMART goals then are specific, measurable, and the A can be either for achievable or assignable, and the R can be either for realistic or relevant, with the T ensuring that things are done in a timely way. So the specific goal here would be to evaluate and follow the best practice for use of multi-dose vials in the clinic. It would be measurable in that through observation, gaps in best practice can be identified and then eliminated. It is achievable in that expired multi-dose vials can be discarded. There can be a review for consideration of single-dose vials, which are actually not that much more expensive and can be an added safety profile feature. And it is both realistic and relevant and could be accomplished in a short period of time. So really looking at, finding the gaps in practice, developing the action plan, using some multimodal strategies such as policies and procedures, looking at an elimination and substitution strategy, ensuring that there are enough supplies, and then education is another important part. So with the policies and procedures, you should also include what education requirements would be recommended. And if need be, then certainly reaching out to any infection prevention and control experts, including Public Health Ontario. And very important then to assign responsibilities for these action items. So it may be in a solo practice, it would be the physician themselves or one staff member. If you're into a larger community clinic, then this could be for someone who has those major responsibilities for IPAC. Someone perhaps might even be certified in infection control, or it could be an office manager, for example. Next slide, please. So looking then at another example, this from the self-assessment checklist on reprocessing. And just a reminder that reprocessing is what you do when you reuse medical equipment. So single-use medical devices are marked with a label. It's a circle. It has the number 2 inside and a diagonal line through it. So any item that has that label is not meant to be reprocessed. So for example, single-use suture removal kits are to be used once and discarded and not repackaged and sterilized for future use. Reprocessing is actually quite a complex process, which includes 7 steps. There's a pre-cleaning process, which should happen soon after the procedure is complete so that you don't end up with dried blood or mucus on the instruments, which are very difficult then to get off. And it should be done with an enzymatic to break down the protein, then safe transport in a closed container to the reprocessing area, which should be separate from where the procedures are done and not in the sink in the room, for example. Then you need to disassemble and sort the instruments and ensure that there's proper mechanical cleaning and brushing of any lumened instruments, and that you may have an ultrasonic cleaner. Then things need to be rinsed and dried, and then moving on, depending on whether it's a critical instrument or semi-critical, in terms of looking at either high-level disinfectants such as glutaraldehyde or steam sterilization and proper storage, which would mean you don't go through all the effort and then put your sterilized pouches near a sink or under it. So back to the 2015 CPSO office inspection review. Deficiencies noted specific to sterilization included failure to use enzymatic on pre-soak, no service contract for the autoclave, improper training of staff on reprocessing, and failure to use biological, physical, and chemical indicators, and failure to record those results, as well as reuse of single-use instruments. So in this particular example, noting that, that medical equipment devices are packaged for sterilization in such a way that steam can move around and through the items and contact all surfaces. So that's where the little red arrow is. A common mistake is overstuffing the pouches, and that can prevent the steam from reaching all surfaces, and it's also more likely to cause a puncture through the pouch. Also in this example is the importance of using the correct chemical indicator. So that's the one near the bottom there, which means using a type 4 internal chemical indicator at a minimum, as well as an external type 1, which you'd be most familiar with in terms of the tape that gets the diagonal black lines on it. But that really just tells you that it's gone through a heat cycle. It doesn't ensure that things are sterilized. So you need to also make sure that the CIs are in the pouch, and they can actually be integrated into the pouch, which is a simpler way because you won't then forget to put one in. As well, each package must be labeled with the date processed, the sterilizer used, the cycle or load number, and the healthcare worker's initials. So this may be a more extensive practice improvement plan than the multi-dose file. It can still meet the SMART goals in that it can be specific and measurable, as there are clear recommendations for documentation. It should be achievable, realistic, it's certainly relevant, recognizing that the timing for this may take a little bit longer. Next slide, please. So similar to the previous example for practice improvement plan, then there are high-risk gaps in the sterilization practice, which are noted, and they're listed there under medical device not packaged according to MIFUs, package label missing sterilization date and initials, CIs are missing on the package. And then looking at some of the actions and strategies that could be put into place, including written policies and procedures per CSA standards. And there is a new CSA standard just out for reprocessing. If this is something you're doing frequently in your practice, I'd highly recommend that you actually get a hold of the new standard. You want to make sure that your sterilizer, packages, and supplies all have their manufacturer's instructions for use. And then if you do have the packages within the built-in CIs, that will help minimize error. So then again, you need to make sure that you assign somebody to this process. This, as I said, may take a little longer depending on how things are functioning with your sterilizer. So this may take 2 to 4 weeks. And then part of that is putting the logs into place, continuing with the self-assessment checklist. Ideally, this would be something that could even be reviewed on an annual basis. Looking at certificates of completion for reprocessing education, and some of the simpler ones are available online through Public Health Ontario, which will give at least a basic introduction. And if you have more complex or high volume of reprocessing that you're doing, then you may consider a more in-depth college program. And so then, what the outcome then, ideally, the sterilization processes are going to be following best practices. You can have things such as signage, again, something that may show the 7 steps of reprocessing, which is a good visual for reference. And then consideration for conducting any future audits. So those are a couple of examples of how the checklist can be used. And did just give you an overview of infection transmission that does happen in clinical offices, and going to our prima non nocere, first do no harm, trying to make sure that we put into place things that are going to keep our patients safe. So remembering to assign someone the responsibility for the IPAC program, ensure that education of all staff is done as appropriate. Self-assess your IPAC practices. You can prioritize your gaps based on the level of risk, developing an action plan with some multimodal strategies, help determine what your desired outcome is for that, and remembering that IPAC practices are something that requires continuous quality improvement. So I'll stop there. This is a list of resources. And you will also be getting a list, anybody who's participated on this call. There's a 2-pager from PHO, which has a nice, a little more in-depth list of resources that are available. If I didn't say next slide, then next slide. And then we'll be coming up to, so there's the summary slide, the resources slide, and then to the last slide then, which is just, if you do have any questions about the presentation or any other IPAC issues, we're certainly here to help, and we can be reached through ipac@oahpp.ca. So I will stop there, and I will turn it back to you, Dr. Mano.
Thank you very much, Dr. Cividino. That was an excellent presentation. And I see that we do have a question in the chat, which we'll get to in a moment. But I just wanted to point out the terrific opportunity here to incorporate the material from IPAC into the practice improvement plan. And I think in my presentation, I failed to mention that the rubric that we use to evaluate practice improvement plans in our program is included in the quality improvement materials that are provided for each participant online. And if we had that rubric in front of us now, we would see that we're looking for each of most members come up with 2 practice improvement goals. And for each goal, we're looking for a baseline. And we want to have a better understanding of where the physician started in their improvement journey. And I really like what you had to say, Dr. Cividino, because it relates to the use of the checklist as a baseline. And then being able to come up with an action plan that clearly illustrates how the physician plans to intervene, and then outcome measures. So it's really a terrific opportunity to focus on an area of practice that some of us may not have at the forefront on a daily basis. I wonder then if Maureen or Rohit would like to take a crack at answering the question that's in the chat, the mechanism of infectious vector transfer by glucometer.
Sure, I can start there. So in terms of looking at it's the contamination of the glucometer itself with the blood. And so that's and it's also felt to be related to the user themselves. So often they're not changing gloves in between. So it's more of an issue when you're having a number of bloods that are being done. So sometimes in a diabetes, not most diabetic clinics these days, but that was an area that happened frequently. What still happens frequently is in long-term care, and you will have, say, 6 people in a row that are going to be having their blood tested, and then the user is not always taking off their gloves and cleaning their hands. So it's in part the contaminant, and certainly with the Lancet hubs, those could be contaminated, but with the glucometer, it often is also related to the user's practices.
Thank you for that clarification. I'm just looking to see now whether there are any hands raised or any other questions that anyone would like to enter into the chat, or I think we also have the ability to unmute folks who would like to ask a question, since we do have a few minutes left. Well, plainly that presentation was so crystal clear that it's now possible for the participants to make use of the materials without having to seek clarification. Rohit, you had a comment?
Yes, I just wanted to end with saying that, while people might be still reflecting on what they heard today, or who might be listening to the video later on, is that we are always available. The email was provided, and it sometimes can be a lot to understand and digest. So feel free to reach out to us in the email that we provided. And we often, when we hear a problem that is common to a lot, then we often plan and organize what we call community of practice meetings, and try to address the problem for many in the province at the same time. And that's a very easy meeting, a two-way dialogue, so people are free to discuss and their challenges and what worked for them. So I see that there's another comment. Okay.
I see. Thank you for that, Rohit. And yes, I think the presentation was excellent, and I'm sure that everyone can benefit from a few minutes added back to their lunch hour. So if there are no other questions or comments, then we can end here. I want to thank our colleagues from Public Health Ontario for the excellent presentation, and also thank you to each of you for joining us in the middle of a busy day. And I'll remind you that the webinar has been recorded and is available on the CPSO's YouTube channel. Thank you, everyone.
Thank you. Take care. Bye-bye now.
Bye for now.